Hey, welcome everybody. Thank you so much for joining our webinar today. My name is Dr. Saru Sharda. I'm a medical advisor and an anesthesiologist, and I'm also the Equity, Diversity, Inclusion Lead here at the CPSO. I just want to check in with folks. Are you hearing a beep every time somebody is admitted right now? No? Okay, great. Just me hearing the beeps. So we're really honored and excited about our guest today. I want to just do a couple of things before we hand over to my colleague Mary Mano and then to our guest Dr. Tara Kiran. One is, of course, to acknowledge the land. Even though we're all meeting virtually today, I'm actually at 80 College Street at the CPSO today. And so I want to acknowledge that this is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. The land is covered by Treaty 13 with the Mississaugas of the Credit. And whenever I do a land acknowledgement, I try and ask myself, what does it really mean to acknowledge the land? What is my action-oriented step or steps towards reconciliation in doing a land acknowledgement? What does it mean to action reconciliation for me, not just as a physician or as somebody working at the college, but as a human being, as a parent, as a spouse, as a teacher, as a leader? And as we know from the Truth and Reconciliation Commission of Canada, reconciliation is the responsibility of each and every one of us. So I would like you to reflect on that as we listen to our guest speaker in a short while and think about what are some of the action-oriented steps that you're going to be taking towards reconciliation, and think about that every time you give a land acknowledgement as well. We have been embarking on much more focused equity, diversity and inclusion work at the CPSO for about 2.5 years now. That has involved a number of cross-organizational approaches, and we are going to be putting links to our EDI reports in the chat, both from 2021 and 2022, which give you a pretty comprehensive look at our EDI work to date. The 2021 report link is embedded within the 2022 report, but I'll ask Tamisha to pull that out and put it into the chat. You're also welcome to visit our EDI webpage, which again, we can provide the link to you. Not only does it contain our EDI reports and an EDI glossary that we have created, it also has a lot of very useful references for you as physicians. And if you haven't looked at our draft health and human rights policy yet, I would also encourage you to do that, because we are encouraging physicians to think and action things like anti-racism, anti-oppression, and cultural humility. And so that policy is still in draft form, but I would encourage you very much to look at it. I'm going to hand over now to my colleague, Dr. Mary Mano. Mary, before she joined the CPSO as a medical advisor, was a practicing family physician for 35 years. She's been involved in the quality assurance program since its inception here at the college in 2019. So I will hand over to her now, and thank you all again for coming today.
Thanks very much, Saru. We're going to be speaking today about using an equity-oriented approach in QI. And the objectives that we have in mind for this session are to, hopefully participants will be able to explain our transition from quality assurance to quality improvement. Also have an understanding of the CPSO quality requirement, and more importantly, use an equity-oriented approach to improve disparities in healthcare and health outcomes for our patients. So my role today is to give a quick overview of the QI program so that we're thinking about the basis for which we can incorporate the equity concepts. I'll just begin with a reminder about the vision that we have here at CPSO. And I think all these aspects are not new to our members, but I want to focus particularly on right touch regulation, which led to a shift in the CPSO. Previously, the quality assurance regulation, as you know, requires that all physician members must participate in a quality program with CPSO. Historically, that occurred once every 10 years in the form of a peer and practice assessment, where an assessor would come to one's office and look at one's records and then give advice or comment on the way the practice was running. In 2019, the CPSO initiated a redesign of the quality program, which introduced QI-based options, and we're still using the QA peer and practice assessment instrument, but in a different way. And the reason for doing this, in large part, relates to this issue of right touch regulation. This is a way of ensuring that the level of regulation that the CPSO is employing is proportionate to the level of risk to the public. And so when we think about quality assurance and contrast it with quality improvement, this is a graph that I found very helpful in learning more about that distinction. In the quality assurance graph on the left-hand side of the screen, you can see that after an assessment, the assessment uses a threshold to judge what is the minimum standard of care that must be met, actions being taken on a small number of individuals. Whereas in a quality improvement model, there's an opportunity for action to occur, for improvement to occur in every person who's participating. And the thinking being that overall, that's going to lead to improvements in quality of care over time. So at the CPSO, the quality improvement programs are organized according to these principles: right touch regulation, QI principles are the basis of our design. And in the end, what we're hoping for is more frequent engagement with physicians. So that the way the program's organized nowadays, we can reach out and interact with every physician member every 5 years. The way that we carry this out is in two streams. One stream is called QI for individuals, and that contains a subset called groups. And the other is QI partnership. QI partnership is the participants in the QI partnership are hospital-based physicians, whereas those in QI for individuals and groups tend to be more community-based members. In 2023, we've also launched a pilot called QI Enhanced, which is a way of offering the QI stream to physicians 70 to 72 years of age, whereas in the past, these physicians were not given the option to participate in QI. They were routed to peer and practice assessment, but we're going to see how well the QI model can be used in these members who are both coming from the partnership side as well as the individual side of the program. So this slide's a bit busy, but it's an attempt to try to give you an overview of the options that are available at CPSO to meet your 5-year quality requirements. So you can see down the left-hand side, the program's QI for individuals. Those folks participate in 3 online activities and submit a practice improvement plan. In the group subset, the online activities are also completed, but the difference is that in QI groups, the group submits one practice improvement plan. In the partnership program, the CPSO requirement is for 2 out of 3 of the QI activities and full participation in the hospital-based initiative. Whereas the QA peer and practice assessment is a different process that involves an on-site assessment. And these are the options that are available to our members. I should point out that when we're evaluating practice improvement plans, we provide the rubric that will be used for evaluation to each participant. And so I'd encourage you to take a look at that. So I've given a very, very brief sketch here just to give you a flavor of what we're up to in the QI program at CPSO. We're very open to communicating regularly with our members. There's information available on the CPSO website. On the Quality Improvement for Individuals page, you'll also find a link to the college's YouTube channel where recordings of these webinars are stored. And the November 2022 webinar in particular contains a more detailed description of the QI program. Also, feel free to email the QI team. Our QI coordinators can help with any technical issues, and the QI medical advisors, of which I'm one, we're always available to support you at any stage through the QI process. So I will stop there, Saru, and I'd be happy to answer any questions at this point or later on in the presentation, but I'm thinking that we want to devote a good chunk of time today to Dr. Kiran's presentation. Thank you.
Yeah, and Thank you so much, Mary. And there will be time for questions at the end, obviously for Dr. Kiran, but if you have any questions for Dr. Mano, you can also bring those forward during the Q&A period. And the webinars that are recorded are really good resources in terms of more details around these programs. So I'd like to formally introduce our guest, Dr. Tara Kiran. Dr. Kiran is the Fidani Chair in Improvement and Innovation and the Vice Chair of Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. She practices family medicine at the St. Michael's Hospital Academic Family Health Team, and she's an associate professor at the University of Toronto in the Faculty of Medicine, as well as having an appointment at the Institute of Health Policy, Management and Evaluation. Dr. Kiran's research, as you will hear about, seeks to improve quality in primary care by influencing policy and practice. And as I said, we're really delighted to have Dr. Kiran here. I've heard her speak before and I follow her avidly on social media. So I'll hand it over to you.
Thanks so much, Sir, for this kind introduction. Please let me know if there's any problems with my slides. Hard to see the chat while I'm presenting, so feel free to just interrupt. But I look forward to this discussion that we're going to have together. So as Saru mentioned, I'm a family doctor, and I think you'll see that as we talk today, that perspective will be front and center. But I hope that many of the principles we talk about, that even if you're not in family medicine, will be applicable to the kind of work that you do as well. I mean, so much of what we do in medicine is really focused on trying to give people the best care possible. We do that when we go to work every day, and quality improvement is about trying to do that even better, taking a systems lens to the healthcare we provide. But I really love this graphic because I feel like it puts the work that we do every day in perspective. So this is a graphic that was pulled together by the Canadian Medical Association a few years ago.
Sorry, Tara, are you sharing your screen?
Yeah, I am.
Okay. I'm checking in with Rachel. Rachel, do you see Dr. Kiran's slides? Because I don't see them, but it could be me.
I don't.
Okay, I'm gonna try.
Do you want to try that again?
Yeah, let's try. Thank you for interrupting me there, Sarah.
No problem. And I know that we have a copy of your slides, so if you're having issues at your end, Rachel can perhaps share on your behalf.
Do you see them now, Saru?
Yes, it's not in slideshow mode, but we do see them now.
Perfect. All right. So I think they'll be in slideshow mode momentarily.
I'll let you know. This exact thing happened to me when I was giving a presentation a few weeks ago, but nobody told me till I was about 5 slides in. But we are now seeing a beautiful slideshow mode. So
wonderful. Okay. So here you see my credentials. But so this is the beautiful graphic that I was talking about from the Canadian Medical Association. And I think it really puts our work in perspective. So, you know, as we see here, really the healthcare you get really only has about 25% of the influence on kind of what makes people healthy or sick. About 15% of what makes people sick relates to biology, 10% the environment. But so much of it, of what influences whether people are sick or not, really relates to life factors, the social determinants of health. So those conditions in which people are born, grow, live, work, and age. And, you know, they include everything from income to education, race, gender, employment, disability, all of those factors that are ultimately shaped by, you know, distribution of money, power, resources. All of those factors have a much greater influence on the impact of someone's life than, you know, what we actually do on a day-to-day basis, often in healthcare. And so important to kind of keep that in perspective, and especially as we talk today about integrating equity perspectives in your work. We, of course, saw this writ large during COVID. Lots written, obviously, about how COVID didn't impact everyone equally. In this slide is from the city of Toronto, where it really demonstrates how people from racialized backgrounds had higher rates of COVID hospitalizations than people who were white, and far higher than would have been expected given their kind of proportion of the population. And disparities in outcomes are also related in part to disparities in the actual healthcare we provide and how that's structured. So this is an example, again, a COVID-related example. And you see here a map of the city of Toronto. And on the left-hand side, you can see kind of when you look at the northwest of Toronto, this was, of course, the area in Toronto that for much of the pandemic was hardest hit. We also know that's the area of Toronto where there is more precarious employment and more crowded housing, lower income, more people who are racialized. So all of those social determinants were at play. But what was also interestingly at play potentially are that there were gaps in care. So this is also a place that actually has some of the lowest number of physicians surrounded really by the highest amount of healthcare need. And we see that on the right hand side illustration. So ultimately, I think what this talk is about is to try and think broadly about this concept of health equity. Which implies that ideally everyone should have a fair opportunity to attain their full health potential and that no one should be disadvantaged from achieving this potential. And how, as healthcare providers, can we help to support this? We saw, the very opposite of health equity during COVID, but as we move forward, how can we try and achieve better? I want to start really this presentation by telling you about some of my own journey and the kind of reflections that it left with me and tell you really a QI story that admittedly kind of takes place over 5 years or so. So I think it's important to put that in context. We didn't do this work just over a few weeks or even a year. It was a teamwork of many people, including one of my close colleagues, Dr. Aisha Lofters, who I worked with for much of these initiatives. So like many of you, I suspect on the call, our team was motivated to try and improve our cancer screening rates. And this goes back to basically 2014. At that time, actually, our team had had an electronic medical record for only a few years and had transitioned to a team-based capitation model and a few years earlier as well. So there were many things out there that allowed us to take a step back and say, okay, this is an opportune time for us to try and do some dedicated quality improvement work. And our physicians were really interested in cancer screening. And so through doing some research about what evidence-based interventions there were, we made a number of changes. We launched a multi-pronged initiative that really the focus of which was put some electronic medical record reminders. We provided data back to physicians about their screening, but the crux of the intervention actually was about outreach to patients who were overdue. So that was the first year we started to kind of mail letters to patients who were overdue, encouraging them to come in for cervical, breast, colorectal screening as was relevant to them. And what you can see here is that we were quite successful actually in improving our cancer screening rates. So you see our screening rates from between, this 3-year period or so. And let's say we look at the green bar, which is colorectal cancer screening, it goes from about 60% to about 70% over those 3 years. So quite a great improvement. But what was really striking was that when we looked at our own data and continued to look at it, what we saw was that although it looked like this was just a good news story, we were doing better, when we looked more deeply, we could see that there were some groups that were being left behind. So again, I want to focus on the very right-hand side, which is colorectal cancer screening. And what you see here is the screening rate by neighborhood income quintile. So this is sort of a measure based on postal code of kind of the income level in the neighborhood a patient may live in. And what we can see in the dark blue is the poorest or lowest neighborhood income quintile, and the light blue is the highest income quintile. And what we see here is actually almost like a 10% absolute difference. So the screening rate in the lowest income quintile was 66%, and in the highest income quintile was 77%. And we had been aware of this kind of difference in screening by income for some time before we did this work at a provincial level. But we were actually quite surprised that at our practice this was the case, because our practice, I think, really prides itself, and at that time, we were proud too of having a very equity-oriented mindset, being very social justice-oriented. And here we were in a practice where there was this stark inequity. And so it led us on a journey. So part of this journey was trying to delve deeper. So what are kind of the factors behind inequities in cancer screening? So our practice actually had been collecting a number of sociodemographic questions that we were able to put into the chart. So these are what we call health equity questions, questions about people's income level, housing, education, and that was all contained in the chart in a way that we're able to extract it. And using that data, we were able to see that to do some work that looked at what the factors were that were associated with low cancer screening rates. And predominantly that seemed to be income related and to some degree housing, but which again, of course, is related to income and wealth. So this is a bar graph that just illustrates that. So patients living below the low income cutoff were much less likely to be screened for all three types of cancers: colorectal, cervical, and breast. So it had us really reflect also on the interventions we had been delivering at that time. And one of the things that we recognized was that the interventions we were delivering the same intervention to everyone, regardless of their background or their need. Basically, we were sending this letter out to everyone, all of our patients in English, tried to make it persuasive, but it was the same letter written for all of our patients. So it was an approach that was treated everyone the same. But we realized, maybe we shouldn't be treating everyone the same. Maybe we need to actually put more intensive resources and have more of a targeted approach, putting more supports towards people who need them more. And so we decided, moving forward, that we needed to do a deeper dive to understand kind of what the barriers were for people who were lower income in being able to get screened and try to directly address those. So that led us to doing this work where we did some qualitative work, first in one-on-one interviews and then in focus groups with people who hadn't been screened but were living with a low income, and we asked them, what's stopping you from getting screened from cancer? And really there were two themes that rose to the top. The first theme was fear. As this patient said, okay, it might be fine and dandy for a person who has not been traumatized in their childhood. I can tell you right now that is the most triggering thing in the universe for someone like me. So there was fear of the diagnosis of the cancer, but there was also fear of the test, particularly for people who had had traumatic experiences in the past, both for men and women, actually, for cervical and colorectal cancer in particular. The other big theme was competing priorities. So as this patient says, trying to feed the kids, trying to keep up, keep a roof over my head. If you're hungry, if you're not thinking about it, you're not thinking about going to the doctor and getting tests. And I think this one is in many ways quite intuitive to us. Our patients are struggling with a lot, and this is just one more thing and perhaps not as high on their priority list. We also asked them, though, what can we do to support people to get screened? And we got a whole bunch of feedback. So they told us about the importance of a strong relationship with their provider. They said phone calls would work way better than letters, that they preferred a wellness-oriented approach, that they wanted information that was very clear. They also wanted the doctors to respect their choice. And so, they wanted the information, but they wanted to be able to make the choice that maybe screening wasn't for them. And then for the women we interviewed in particular, they were open to having group sessions and thought that could be helpful and were interested in a warm tone, whereas actually the men were less interested in a warm tone and kind of wanted someone who would just lay down the law for them and speak to them a little bit more sternly, perhaps, about what it is that they needed to do. So all of that work led us to a few different things. For one, I should actually say that we did start to kind of prioritize phone calls more for people with a low income. Phone calls were actually much more time intensive than letter sending, but we decided to try and prioritize that intervention more for people with a low income because we also knew it worked more. We then piloted also this group educational sessions that included an opportunity for screening during the education session itself. And we learned a lot actually from doing this. So the initial pilot, we called 87 women who were overdue for 2 or 3 screening tests. Unfortunately, a lot of them couldn't be reached, and some of them declined to come. In the end, for our first pilot, we had about 15 who agreed to attend, but only about half of those attended. The people who attended thought it was terrific. One participant remarked, "At the age of 51, I finally learned where my cervix is." So it was really terrific for them. And most people who attended got their pap test or mammogram, so they got the pap test that day potentially, and we actually arranged to have them kind of take a taxi to the mammogram center right after the workshop if they wanted. And they all took home, at that time it was an FOBT kit, but none of them returned it. So interestingly, I'd say pretty mixed picture in how successful we were in being able to actually make a difference in equity despite kind of all this understanding work. And I think this was really a humbling experience for me. It taught me that, in many ways we were doing things right, but there were also some things that we needed to do better in order to make more of a difference. And so we can talk further about it, but here are, just a few of the reflections. I think what was good about what we did was that we tried to identify and address the needs of a group that was left behind. And I definitely encourage you, and we're going to talk more about that, how that you could do that as you think about your quality improvement project. We tried to match the resource intensity with patient need, using more of our resources for people who were more in need. We definitely tried to co-design our solutions with patients, but some of the places where we, for example, fell short, ultimately, so we weren't measuring informed discussion. We were just measuring test receipt, and actually our patients really wanted this choice, and so a better measure would have been informed discussion. And we have tried to do that in our practice, but it is actually a tough thing to get physicians to document in a standard way. And then the other thing that was really fundamental here is that our patients, they said that they wanted a tea and cookies kind of approach. When we did these qualitative interviews, they wanted us to actually come into their community and meet them where they were at. But doing kind of these community-oriented interventions was tricky for us as a big family health team, because we didn't care for everyone in the community. And at the same time, if we looked at who our patients were, they were all over the GTA. So it's not like we could be in all of those communities either. So the way primary care is kind of organized just like set up some barriers, and in many ways it would have been ideal if we could have partnered with a community organization. So this is just sort of a reflection of a lot of work we did that tried to advance health equity. We wrote about it we have this very kind of practical report that you can access on our website that I'll share with you, because I know many of you are working in the cancer screening space. It talks about the work we did to improve cancer screening rates. It also talks about the kind of the work we just reviewed. It also talks about work I didn't talk about today, but we'd be happy to, where we try to actually improve cancer screening rates among our trans population, which is a different group with disparities. Ultimately, though, I think this work helped me to reflect on this diagram and our approach to equity even more deeply. I know a lot has been written about this, pictorial about equality and equity, and we could have, I think, a long discussion about it. And I've been to workshops where that have really opened up my eyes to kind of the subtleties here. But I think it is more than about just giving more resources to a group that is underserved or disadvantaged. In this case, the disadvantaged group are the short people in relation to the tall people. And we can see, okay, they've got 2 boxes here, all said and done, but maybe it's not. And I think if we reflect even more kind of on this picture, we can see that ultimately, what's keeping these people back from being able to enjoy this baseball game, which I would say is kind of a metaphor for access to social capital, is the fence, and the fence that's keeping them from fully participating in society. And that fence, who constructed that fence, and who is most blocked by it? And so much, the fence is really kind of a metaphor, I think, for our system. And our system really has been designed, in this case, by the tall people, but also the privileged ones. And it's really important for us as providers to help to see the fence that we may not see, because often we are the tall people, see what the short people are seeing, so the people who are less advantaged, see the system from their point of view, and help to dismantle the system, to be honest, that's keep holding people back and keeping people from ultimately accessing social capital that will allow them to thrive. And so I hope that you'll reflect on that as I take you through a few kind of practical things that you can take away for your quality improvement work that you're doing, both within the CPSO context and hopefully beyond as well. So I've listed here 6 strategies for taking an equity-oriented approach to improving quality, and I'm going to go through each of these 6 in turn, and I'll share with you a couple of resources at the end that I hope will be helpful to you in terms of further learning and specifically in your QI project. So the first is to prioritize the needs of populations experiencing the worst health outcomes. Through all my kind of work in quality improvement over the last decade, I've realized one of the most important things is deciding what you choose, where you choose to place your quality improvement efforts. And more, I have tried to choose areas that disproportionately affect people living with disadvantage. So for example, after working kind of on this cancer screening area, we started doing work in the area of opioid prescribing, because we know opioid deaths are disproportionately affect people who are living with a low income. Similarly, our practice took it upon themselves to try to do some work to help improve hepatitis C treatment rates. Actually, prior to COVID, I think hepatitis C was the one infectious disease that contributed to, I think, the most early mortality and morbidity. And at the same time, it was actually, something that could be cured with new drugs that were available that were also hard to put into practice. And so our team kind of did a quality improvement approach to try and identify who needed Hep C treatment and ensure those people get it. Again, people with Hep C, they're more likely to be from marginalized communities, use substance, be underhoused, potentially previously incarcerated, or living in poverty. And so just by virtue of focusing it on this area, you are helping to address issues of equity. What are some other ways in which we can think about that? So as I think about all of you on the call, I'm sure many of you are family doctors. We know one of the things people are talking about all the time now is how way too many people in this province and in the country don't have a family doctor or a nurse practitioner that they can see regularly for care. And we know that's so critical to people being able to thrive and connect with the rest of the healthcare system. So if we take this strategy and apply it to that problem, which I would say is probably the #1 problem, how perhaps it's a way then of us thinking, if we are taking in new patients, which groups of people should we be prioritizing? And interestingly, some of the data that has come out about people who don't have a family doctor, we know that people who are living with a lower income, people who are more racialized, those are groups who actually are less likely to have a family doctor. And so those are groups I would say that we should be prioritizing as new patients. The second strategy is to stratify your data. And you can do that by collecting new data yourself. That can be very time consuming and intimidating. So the alternative is to use data that's already collected. So I mentioned that in our own setting, we had been collecting health equity questions based on some work that was done by this collaborative in the Toronto area, probably about a decade ago. The questions have now been updated by my colleague Andrew Pinto, who leads the Upstream Lab. And so if you're interested in more about how to collect sociodemographic questions and information for your patients, feel free to connect with me after for some resources. But I wanted to illustrate kind of how we've used this in our own work. So you saw us how we used neighborhood income quintile and the cancer screening data to better understand inequities there. So that didn't require any new data collection. We had postal code information, and we could use postal code information to kind of match that into neighborhood income quintile. Again, that may be hard for your practice or your setting. Another kind of area that many of you may be working in is patient experience. So this is actually a some data from a patient experience QI work that we did several years ago, where we looked at various dimensions of access and patient-centeredness. And what you can see is sort of these two dots between 2014 and 2016. And one of the things that I like about these graphs and what they illustrate is you can see the after hours, the access to after hours care in the middle. We can see through the dotted green line how overall the access to after hours care improved as a result of quality improvement interventions we did in our practice. Now, in the survey, that patient experience survey we did, which collected this data, we also asked sociodemographic questions, including about questions about self-reported health. And interesting though, when we stratified the data by self-reported health, you could see that people who reported excellent health actually experienced far greater improvement in after hours access than people who reported poor or fair health, which helped us to put context into our improvements, that yes, we should be proud of them, but that there was still a really important group that was kind of being left behind here, who was still continuing to report struggling with after hours access, perhaps the people, I would say, who needed it most. I did wanted to tell you a little bit about this tool, because I know many of you, it's perhaps, collecting this data seems intimidating, but we have a new tool that I'll tell you more about at the end of the presentation, Care Canvas, that's available for any physician who's on one of 3 electronic medical records. It's available for free, and we actually stratify some of the data by income. So this is an example of blood pressure control for people with diabetes stratified by income. This is all kind of fake data here, but you can kind of get the sense that you can see how people might be faring differently based on their income level, and it can help you to identify inequities and target them. The third strategy is to partner with patients and communities. So we certainly illustrated that with the cancer screening work, and there's a range of ways in which you can partner. So that could be anything from identifying the priorities, understanding the problem, co-designing solutions, testing the solutions and interpreting the data, or then just moving to spread and sustainability. Partnering with patients and communities, particularly when you're thinking about equity, is so critical because of that what we talked about earlier, that what they're seeing in their perspective is very different from what we experience, and unless we partner with them, we won't be able to understand what they're seeing, what the barriers are, and the potential solutions that might work. I really love this story, this work that actually a colleague of ours led, Dr. Anya Norum, at the Taibu Community Health Center. And I think that actually the title of this article is terrific. It says, Toronto Health Center's cultural humility focus led cancer screenings to surpass provincial averages. So this was an Afro-Caribbean focused, Black focused community health center in Scarborough that had very low cancer screening rates for many years. And then they really took it upon themselves, the center, to try and address this. And they addressed it successfully through partnership with the community, listening to what it is that the community want, and organizing kind of initiatives and strategies, multiple initiatives and strategies that really drew from the community's ideas and that were culturally sensitive. And when I talked to Anya and my colleague Aisha Loftrup about some of this work, I think this notion of cultural humility really spoke volumes in terms of in order for us to really address equity and work with communities, we need to approach everything with cultural humility, understanding that we don't have the answers. The fourth strategy that I'd like to share is to consider the resources available to particular populations. So this is pretty practical. What resources are available? Do people have barriers related to their finances, their education, transportation, their work schedule, their living arrangements? And then how are the needs or solutions potentially different? And one of the things for those of you who are really into quality improvement, you may recognize the cause and effect diagram, which is a tool that we teach as a way to kind of get at root causes of a problem and then can help you to understand potential change ideas. And one of the things we've encouraged our resident trainees to do is when they're doing a cause and effect diagram, actually is very specifically put a social determinants of health arm on it. So is there, let's say the problem that we're trying to address is people being co-prescribed opioids and benzodiazepines? Are there social, perhaps their provider or policy issues or patient issues that specifically lead to that? But maybe there are also issues related to the social determinants that are, whether that be poverty, a history of trauma that relates to early childhood, that may be affecting that outcome that we need to really be mindful of and draw out as we think about our intervention. Similarly, when you're doing a literature review to think about what strategies might be helpful, think about doing literature reviews that are very focused on what interventions have been helpful for specific marginalized populations you're thinking about. As an example, I think this is a picture of the Sherburne Health Bus, bringing care literally to people who aren't able to go and seek it themselves. Maybe they don't have a health card on them because they lost it. They have all those competing priorities we talked about that are often barriers to engaging in health care. They don't know, they don't have a doctor. This is a way to potentially bring screening to some of the people who are most at need in a way that's convenient and meeting them where they're at. The fifth strategy is to potentially directly address the social determinants of health from within the system. And here I'm just citing an older study that was done actually in Boston in some pediatric clinics. And in these pediatric clinics, they actually screened for social needs. They screened moms who were coming there with their children for social needs. And then if they screened positive for social needs, the providers made referrals to the families for a variety of things. And these weren't necessarily actually intensive referrals. Sometimes it was just connecting them to someone. Sometimes it was providing them with a resource. They then followed up, and not surprisingly, so this was a randomized trial, and the mothers who were screened and who had the opportunity then to have that intervention, they had greater odds of enrolling in a new community resource, greater odds of being employed, greater odds of having kids who are in childcare, and lower odds of being in a homeless shelter or having to of being in a homeless shelter, and greater odds of receiving fuel assistance. So really striking results that illustrate the power of screening for social needs and trying to address them directly within a medical setting. So when we think about our own medical settings, again, this is an example from primary care, but actually could be used in a number of outpatient clinical settings for specialists as well. There's the opportunity to screen, for example, for poverty using this one simple question: do you ever have difficulty making ends meet at the end of the month? And so we know poverty, of course, is a big risk factor for many issues, which we've just talked about. But there are also some interventions. So if the patients say yes, something very specific, as an example, that you can do is ask them if they filled out their taxes. Because filling out your taxes is often like the first step for being able to be able to get some of the benefits that they would be eligible for. So that's just one of a few different kind of concrete interventions that this tool that the Center for Effective Practice and my colleague Gary Block have helped to develop. The sixth and final strategy here is to influence the structural determinants of health. And so this really and requires us to take a step back and to reflect on how there are root causes for even those social determinants of health. So if we think of inequities related to housing or income or education, so much of the time, those inequities are actually rooted in something more deep in our legacies, for example, of colonialism and the way that we have treated people who are Indigenous as a country unfairly and unjustly, and continue to do so. They go back to roots of racism, sexism, transphobia. So many of the manifestations, the social determinants of health, are really rooted in these underlying, I would say, root causes or structural determinants. And those are, nicely illustrated in this diagram that one of our former residents, Nanki Rai, put together. Now a fully fledged family doctor who's out there in practice. But I would just like, I think it's important for us to reflect that part of our role here is to educate ourselves constantly about and remind ourselves about our own place and privilege and how that infects how we interact in the world and the way we see it. To reflect on how we can be an ally for those who have less privilege, and how we could actually act in our own institution or more broadly to try and address some of these root causes, whether they be the legacies of colonialism or racism as examples. As we close out the session, I want us to reflect on this saying of, whether or not we are all in the same boat. I think when COVID began, there were many people who said, COVID's the great equalizer. We're all in the same boat together in this, really difficult time. But as the pandemic wore on, it became really clear that some of us were like on luxury cruise liners and others were on a raft with very little to like kind of propel us and protect us when the waves were high and things were scary. And so I would say more than anything, the pandemic has shone a light on how we're not all in the same boat. We may be trying to navigate the same waters, but some of us have far more resources than others. And then when we're doing our quality improvement work, when we're thinking about our role as physicians, how is it that we can help to equalize things? And it obviously starts with this recognition that we're not all in the same place. So just as we end up here, I wanted to share a few resources. The first is actually if you enjoyed this talk and you wanted to dig deeper into into health equity or into quality improvement more broadly, we encourage you to access our free online self-learning modules. There are 9 modules in total designed specifically for community clinicians. They do have a primary care focus, but many, I think, of the modules have material that would be relevant to people in other specialties as well. 9 modules in total, and you can see improving equity is one of them. And so this is an example of the equity module. It's a beautifully done, I would say, on Rise platform, which is easy to use and navigate, and you can kind of pop in and out to the areas that you find most interesting. And then I also wanted to share with you our tool Care Canvas that I mentioned. So this is a new tool that we just released in the fall, and we're getting set. We're hoping to launch our next iteration in the fall of this coming year, and hopefully as things keep going, we're planning on putting out a dashboard every 6 months. This is a summary of data from your electronic medical record. There's no cost to participate. You have to be using TELUS Practice Solutions, Accuro, or Oscar. We would extract data from your records. They would support research, but also you would get back this quality improvement dashboard. Again, very easy to use, and you can kind of see a prototype at carecanvas.ca. And as I mentioned, one of the great features is that you can kind of do a deep dive from an equity perspective on some of the metrics. So thanks again for the opportunity to share some of my thoughts and reflections today, and I look forward to your questions and comments.
Thank you so much, Tara. Oh, I'm getting a bit of an echo. Not sure if other people are. We have a question in the chat and a hand up, so I want to go to those, but I just want to maybe offer a couple of quick reflections of my own. And I think the first one relates to Belinda's comment and question in the chat, which is really when you were showing that equity diagram and that picture that so many of us have seen. The thing that resonated with me the most was when you really encouraged us to think about who built the fence. Right. And how do we think about who built that? So it's not actually just about the fence or the steps. It's like who built the fence. And I think that kind of ties into your slide from Nanki with those structural determinants of health, and remembering that they are so kind of deep rooted and need complex solutions that are multifaceted to uproot them. And then the other thing I just wanted to touch on quickly was when you were talking about if folks don't have race-based data, for example, what does it look like to collect that kind of data? That there are very specific practices and guidelines and governance around how we do that well. So it's not something that we just start to do, but you offered kind of guidance around that. And so I just wanted to highlight that. So I'm going to maybe let Belinda. Belinda, would you like to unmute your mic and ask your question, and then I'll go to the raised hands. Not sure. Are you still there, Belinda? Would you like to speak your question, or it won't allow you to unmute? Okay, I will just ask Dr. Kiran then. Belinda's question there is, I think, what we have already been talking about, who continues to benefit from the fence. And then we have Shanaz asking, are there populations that are left out in our data, like undocumented and temporary foreign workers, which I think actually relates to Belinda's initial question. So maybe we'll group those two together for you, Tara, and then we'll go to our raised hand.
Thank you. Yeah, great questions and points. So absolutely, there are populations that are left out in our data. Certainly, when we look at administrative data, often that requires people to have health cards and for them to be counted. And so people who don't have a health card are often not counted in those kind of data sources. Now, the benefit, though, is that if you are doing quality improvement based in your practice, which you can use small sample chart audits, you can include that data. So that is a weakness at a systems level, but I would say one of the opportunities is that you can try and address it when you're doing your own kind of local QI work. An example, I guess I would say, is at a systems level, it's not captured whether someone is trans or not. For a long time, the health card was binary in the way that it collected the gender data, and I know that's changing. But the way that Cancer Care Ontario would calculate screening rates and set automatic reminders would mean that they would often misclassify people who are trans. So let's say you were a woman who transitioned to a man and you transitioned socially, but you hadn't transitioned surgically. You would still have a cervix, but your gender marker on the health card might be male. And as a result, you would be left out of cancer screening recall reminders. And so when we tried to do this on a custom basis within our own team in terms of creating our own recall system, we now flag people who are trans for the clinicians because clinicians told us this group of folks was missing. And so, yes, people are left out, unfortunately, of some of our bigger data systems, and that's an issue. Those are issues we need to address. I think one of the benefits of local QI is that you can address them within your own setting. I think, Cheryl, you answered, I think, Belinda's question actually quite well in the way that you reflected on it. Absolutely, like it was what I think your comment in the chat, Belinda, was probably before I showed that diagram from Nanki Rai, because I think that diagram really nicely illustrates the connection between the social determinants and the structural determinants. And those structural determinants, ultimately, so much of them are about power and position and distribution of resources and legacy. And that can feel very overwhelming, which is why I encourage people to start by reflecting on their own privilege and what they can do within the setting that they are in, because many of us, for example, are employers. If you run your own small business, you're an employer. How are you? What kind of anti-racist, anti-oppression framework can you bring to your lens as an employer or as a colleague? Like, there are many day-to-day interactions or responsibilities we have where we can bring those lenses. So trying to bring it back down to that. And then just so you also mentioned, I actually didn't talk about this in detail today because, to be honest, I felt that most people are probably not going to leave this seminar today and go out and collect race-based data. It is a very complex undertaking that requires a lot of community engagement and partnership. Like, more than engagement, it requires community partnership. And so I actually deliberately didn't talk too much about it because communities need to govern their own data, and when they don't, there are some, can be some really negative consequences, and it's particularly true for race. I think some other dimensions of sociodemographic data collection, like income or education, are less sensitive, and I think I would encourage people to think about collecting those types of data.
Thank you. We have Shanaz with her hand up, and sorry, with their hand up, and your mic should be enabled, Shanaz.
Thank you, Tara, Kiran. Your talks are always so inspiring. And we've known this data even before the pandemic. The pandemic just threw light on it. The areas that are very deficient in primary care are the same areas that were the hotspots during the pandemic. The problem is, who is building the fence? Are physicians the fence, you know? And I won't name any organizations, but, you know, we have this data, we have to act upon it. I'll give you an example. Giving bonuses for doing pap smears, sending people for mammograms and the like, you know, giving flu shots. I thought that you did that because that was good for the patient's care, that it had downstream health benefits. Giving bonuses, I think, is a detriment to doing that kind of service. And my question is, in order to get the marginalized population included in the screening, the US has uses technologies other than what we are using, like self-collection of pap smears. The FIT tests, the forms are so onerous for physicians and patients alike, you know, to go through a FIT test. Could we simplify some of these procedures, think outside the box, use AI, other means of getting more marginalized populations included, and they are the highest risk ones?
Yeah, those are a lot of great points that you made. You know, especially maybe I'll pick up particularly on the self-sampling for people being able to, for example, do their own PAP. We know that empowering people to be able to understand their own health and address it and give them the tools, you know, that can address a lot of the barriers. So whether that be, you know, they have, you know, many women feel uncomfortable going to a male provider for a PAP test, but their provider is male. So, but, you know, if they had the opportunity then to do it at home with their own kit, that could really address things. Or perhaps they, you know, it's their social network that can help to influence them around the importance of those things. So absolutely, there's so many strategies that we need to be using to try and to address, you know, sociocultural barriers that, quite frankly, are also heterogeneous. So that's the other thing, you know, to consider, is that what works for one community might not work for another.
Great, thank you, Tara. We are at 1:01. I want to just kind of quickly go back to the chat, recognizing that some people have to log off to go back to clinic or do other things, which is completely understandable. I'm sure that Tara and Mary have to go shortly as well. But is there, maybe we have time for one quick question. If anybody has anything they would like to raise their hand. There's some really lovely comments there, Tara, saying how useful this was. Just looking to see. We do have a little bit of a question for you, Mary, which is that I'm just looking for it now, which is, if somebody completed QI at 69 years old this year, do they need to complete enhanced QI next year? If they have completed enhanced QI at 70, when is the next QI?
That may be a question that depends on the individual's outcomes. So if that person would like to contact me, I'd be happy to discuss their situation with them.
Great. That sounds like a great idea. And I think that we're going to put a QI email into the chat. I just want to thank everybody for coming. I want to thank you, Dr. Kiran, for, I think, giving us a really great balance of what is a very complicated problem, but being able to give folks some very concrete ideas, some ways to move forward, albeit small steps, and really importantly to think about how we're contributing to the building of that fence, and how are we ourselves that fence as physicians, and how do we start to dismantle and break that down. So thank you so much. This is going to be recorded. I just want to say thank you to April, Rachel, Bonnie, and all the other people behind the scenes who are so expert in putting these together. And thanks again to our guest and to my colleague, Dr. Mano, as well. Have a good afternoon, everybody.
Thanks, everybody.